25, 5, 4, 3, 1. Or live.
Good evening. This is Jacques Morcos, and welcome to the monthly episode of University of Miami Cerebrovascular Skull-Based Surgery Symposium. This is, believe it or not, session number 47 today on September 15, 2022. We have a great panel. We have a great topic. We want to talk about treatment controversies in AVMs. I'll introduce the three speakers in a few minutes. I remind you who the co-directors of this long series now are: Carolina Benjamin, Mike Ivan, Bobby Stark. I've introduced them, of course, many times in previous sessions. And we are joined always by our Cerebrovascular and Skull-Based Fellow. That's Matthew Sun for this year, who's doing a fantastic job. Came to us from UCLA, and our infolded resident infolded CV and skull-based fellow, Eva Wu, who's a PG4 in our program. They will each present a case to our panelists after their lectures. Many thanks to the team that makes these symposia happen, particularly Ignacio Escalona, who is here with us running this webinar. Those of you interested in reviewing previously recorded, all of them have been recorded and are on our YouTube channel. You can see some of the info here. If you want to reach out to us, you can see some of the links and Twitters and so forth. To remind you, next month, on October 13, we'll have a great panel on surgical management of acoustic neuromas with Ashok Astagiri, Martin Samez from the Czech Republic, and Mustafa Baskaya from University of Madison in Wisconsin. So please join us if you're interested in that topic. Our speakers tonight, none of them really need a formal introduction, and they all, of course, have been participants in our series before, but in the order that they will speak, and I've asked each of them to speak for 20 minutes. First, Amir De Dashti. Amir is professor of neurosurgery and director of cerebrovascular and skull-based in the Northwell system in Great Neck, New York. Amir will tackle the interesting topic of assessing operative risk and predicting surgical outcome. Next will be Gary Steinberg, of course, the chair emeritus at Stanford. You cannot mention Stanford without mentioning Gary Steinberg with it. Microsurgical treatment of eloquent AVMs. It's been a pet topic of his for many years, and he has published extensively about this topic. So it's great that he could join us. And last but not least, my good friend Adam Arthur, who will talk on role of and spectrum of embolization. Adam, of course, is relatively new, chair of neurosurgery and professor at Sam's Murphy Clinic. Nobody was more deserving of this post than him at University of Tennessee, Memphis. And you can see why we have a fantastic panel, and we will have fantastic discussions at the end. So I'll stop talking. Amir, please share your screen, unmute your microphone, and start your presentation. Okay, just see. Can you hear me, Jacques?
Make it full screen first. Yeah, you got it.
Okay, Jacques, thank you very much, you and the rest of the team, Robert, Ben, and Caroline, everyone. I'm thrilled to be back. And thank you very much for suggesting the AVM topic, which is one of my favorite topics in neurosurgery. And I will be talking, according to your request, on assessment of surgical risk and outcome in obviously complex brain AVMs. And I would like to focus on unruptured AVM because this is really the area of controversy, and that's the topic of your session, which is really the controversy. This 27-year-old female was referred to me by one of our secretaries, actually, is the cousin of one of our secretary. This complex AVM is probably as complex as an AVM can get in terms of deep location, deep venous drainage, as a callosal AVM. Basically, this was diagnosed out of the blue. She had no symptoms whatsoever. She had a trauma, car accident, and this is her lesion, a callosal AVM with lots of en passage vessels from ACA, significant venous drainage. And without going into too much of the debate, ended up treating this patient because she was very uncomfortable with leaving it alone. She said, I think she asked for probably 7-8 different opinions from different places. Embolization followed by a surgical resection, and that was 3 years ago. This is, you see the pictures post-op. We preserved that ACA, and the AVM was completely resected. She had some left-sided deficit. She had some cognitive issues after the surgery. No obvious stroke on MRI. She was not herself for the first 6 months or so. They would say she's different. Although she would look at her, she would look pretty normal. But now 3 years out, AVM follow-up angiogram shows cure still. And she's back to baseline. She's working. She has a kid and a family. So at the end of the day, I think we did the right thing. But the more difficult thing is to decide whether we should have treated on this or not to begin with. Now that we have the results, it's easier to judge. But at the beginning, that's a difficult decision. And Aruba is not here to help us. There are lots of issues with Aruba, even if with the 5 years results that was relatively recently published on Aruba that still favors conservative management on brain AVMs. There are lots of issues, including randomization. A comparison to surgery in Aruba is irrelevant. There were very few patients, only 18% had surgery. And there is a high incomplete obliteration rate, which is kind of a nonsense in AVM treatment. Whether the AVM is cured or it's not. And if it's not, then discussing about the outcome, to me at least, seems irrelevant. And many, many studies, I just mentioned two. This is from Toronto and very recent one from Massachusetts General Hospital evaluating the same type of patients. This was a series of 318 patients, and they looked at the same key safety endpoints that Aruba looked at. And if you look, you see that the results in terms of the stroke and MRS risk are 9.2% and the poor MRS in 14.3%, similar to the conservative arm in Aruba, not anywhere close to the interventional arm. So all this favors the fact that we should be aggressive or more aggressive than Aruba for unruptured AVM. Now for AVM, you can look at different risk factor for hemorrhage. You can read by yourself, but most importantly, an AVM with prior hemorrhage, AVM with deep venous drainage, deep location, and most importantly, intranidal or prenatal aneurysms. They are more favorable or more vulnerable for rupture. This study that we published in Stroke many years ago shows that if there are associated with intranidal aneurysm, the risk of AVM rupture almost doubles per year, is close to 7% per year. So all this aside, recent study, this is one of them is run by Robert, that the national survey has shown that over the recent years, the incidence of rupture of brain AVM has increased. And this is another recent study on the right side showing that the rupture of cerebral AVM has increased post-Aruba from 13.3% to 34.4%, with a mortality almost quadrupled. So there is something that the society is doing wrong now after evaluation of Aruba, and at least based on these studies. Now, whether you believe in them or not, but at least these are the data recently published. Now, how we can evaluate the risk of an AVM treatment or surgery. When we look at the classification, and I was a fan of all this classification at some point, and I just realized now that except for Spessler-Martin, fortunately or unfortunately, all of the other classification, you name it, the one in Toronto in 2006 from Julian Spurs, which is a very good classification, but it's complicated. Or the one that I like actually is a really recent one from Jiao in Shanghai, that they look at the proximity of the AVM to eloquence and diffuseness, deep venous drainage, and hemorrhagic presentation, and also a specific classification for posterior fossa AVM by Nissan et al., and the supplementary grading of AVM. None of these is really used by almost anyone than those who wrote these papers. So if you look really in the practice, who comes in and say, oh, this is a Spears grade 6 or Jiao grade 5, no one talks or mentions. And I bet many of the cerebrovascular surgeons do not even know or cannot even describe this classification because these are complicated and not practical. And that's the genius about the Spessler-Martin classification that remains by far the best classification stem. Now, if you would like to look, you can, and I do personally look at all this classification, add the numbers, and see where we are in terms of estimating the risk for an AVM that we decide to treat or we decide to observe. Dr. Lawtons and his group at the Barrow evaluated just very recently the intermediate, basically, risk AVM, and they got to the conclusion that when they use their supplementary grade plus the Spessler-Martin grade, if they get to 5, the risk of operation is about 24%. That gets to 29% if they are grade 6. And that's sort of the cutoff. And then when they get to 7, suddenly the risk jumps significantly. So they basically put the cutoff at 6 for vast majority of patients. So all these things has to be included into the decision-making for a given AVM. Now, these are all theoretical. And in real life, we deal with the patients, and we can't go and put all these numbers and come to the patient and say, but based on the Spears and Nissan and et cetera, this is your risk. So in real life is different. We look at the indication, we look at the eloquence location of the AVM, which is, to me, along with the diffuseness, or the real 2 major factor of decision-making for treating an unruptured AVM. And then we look at all other things that can be associated with estimating or improving surgical outcome. Endovascular embolization, I think, is very helpful. The Society of Neurointerventional Surgery, I don't know if Adam was part of this guideline, I'm sure he was, recently published this paper that validates the endovascular treatment in all aspects of AVM treatment, including endovascular embolization for cure, for preoperative preparation, for palliative treatment, and also pre-radiosurgery. Now, it might be a little bit too vast, but I think a good embolization before the surgery is very helpful, and I do it for vast majority of my cases. Surgical planning, surgical technique affects the surgical outcome, regardless of what is the grading of the AVM. And advancing technology, including 4D angiogram, augmented reality. I'm just going to show you this case. This is a recent case that I just want to show you the use of augmented reality. This is a relatively simple left frontal AVM with the feeders from the Soviet fissure that you cannot see them really. And this is Dr. Kwok, my current fellow, operating. And here on this picture, you can see the augmented reality shows him where are the feeders that are going to the AVM, right there. So he can directly dissect and separate, open the arachnoid, identify the nidus, identify these feeders, and directly get on there. Now, of course, if you're an experienced surgeon, you don't need that. Experienced surgeon will find a way to get around this AVM. But at the beginning of your career, and also in order to improve the efficiency and safety of procedure, you can see that this could be very helpful. You can see the direct feeder going, where is the extension of the nidus, and you can see where the draining vein starts and where it leads superiorly. So the augmented reality has become a very important tool in surgery for us. And I thought that case is very interesting because it helped really my fellow to get around this AVM using the advantage of the augmented reality. Then management of intraoperative bleeding is very important. That affects surgical outcome. intraoperative and postoperative blood pressure management. And finally, I think the frailty index is something that is probably was not paid attention much before, but we know now based on multiple studies, including this recent one published by University of Washington, Seattle, that older patients do not do as well. So we have to take that into consideration. Now, in terms of technique for surgical resection of AVM, this is a patient with a grade 4 Spessor-Martin. You can see it's a complicated AVM, about 4.5, 5 centimeter, 28-year-old with seizure, has feeders from all the 3 territories, superficial and deep venous drainage. And seizure, obviously you can decide to say, well, this is a complicated AVM, we should leave it alone. Natural history and seizure is okay, but we decided to treat. Also, I think that these AVMs that are in the somatosensory region, in terms of eloquence, are a little bit different, obviously, than if they are smack in the motor cortex. We did 2 sessions of embolization, and then we followed that with resection of this AVM. So, as you can see, it's just posterior to the motor cortex. And if I can advance my slide here, the 3D angiogram is visible. Just going to go back and forth once because I'm not able to advance this, unfortunately.
Amir, what if you grab that circle that's in the menu bar and drag it? Sometimes if you can see that circle that shows up.
That's a problem. I cannot see that circle.
Oh, okay.
What I can do probably is to escape the mode and go back to view one more time like this. That might help. Yes.
Yeah, here you go.
Yes, yeah. So this patient was taken for surgery after 2 sessions of embolization. And what I would like to focus on is how to deal with these deep white matter feeders. So here, when we get, this is really the, I would say, art of AVM surgery, to get around these deep white matter feeders, as you see in this one. Prepare each side of those feeders very carefully and leave enough length and room to get around them. And you see after multiple coagulation here, that feeder is still potent. So I would put a clip on them before cutting them. So that's one way of getting around this. And this has to be repeated one after the other, no matter how long does it take. This is not a surgery that you can do quickly, or else it's going to become an ugly surgery. If you want to keep it pristine and elegant, that's the way to do, to go and work with every single feeder like this, identify the deep venous drainage here, and then just get around the nidus. I have learned and prefer to work around and go down as opposed to creating in one line and work on one side of the AVM all the way down to the deep part. Here you can see there are 2 MCA vessels going to the nidus, one that is embolized with onyx, which still has flow in it, and the other one that completely open. You see, this is onyx in it. I wanted to show you that. Completely onyx vessel. I coagulate it and I open it, still bleeds. So that's those who think that onyx will completely cure a vessel. That's an exact example that it doesn't do sometimes. And for big arterial vessel, I prefer to use a clip before coagulating and cut that vessel. And then eventually, obviously, I'm not going to show the whole video. This is getting around the nidus of the AVM, separating the nidus carefully, meticulously from the surrounding brain. And this AVM extends to the ventricle. That's the important part. We have to get to the ependymal surface. And here, by getting around, we're getting to the deep part, separating the AVM and exposing the ventricular part of this nidus. So we are getting in the deep location of the AVM. Here you can see the nidus is separated here. This is opening of the ventricle. And here, that's where we will see the 2 draining veins going toward the deep venous system, which has to be disconnected. And that's why this AVM, if we don't explore this region, obviously we have to cut through the AVM. It's going to get lots of bleeding, and eventually you will leave a significant residual. And finally, by getting around the nidus, disconnecting that part from the deep part that is inside the ependymal surface and deep feeders from the choroidal arteries. Again, the same technique over and over again. Create enough length for these deep feeders, even if they are very deep, to separate them and avoid them bleeding. And then once this deep part is done, this AVM is only connected, basically. Ventricular wall is completely open. You can see here the plexus choroid. And AVM is only stuck now to his two main final draining vein that are disconnected and removed. And this patient did have sensory deficit after surgery, but no motor deficit, and the sensory deficit improved. She came 6 weeks after to my office and walking normally and has virtually no real objective symptoms that bothers her. So this is the imaging after intraoperative angiography. The other AVMs that I think that are important in terms of the complexity or AVMs in the sylvian fissure, because they are fed by lots of on-passage vessels from the MCA. This is again a very young patient, young woman with seizure, insular sylvian fissure AVM. We did a couple sessions of embolization on this AVM. As you can see, is a complex AVM, has both drainage to the sphenoparietal sinus and the basilar vein of Rosenthal. And after embolization, we take the patient for surgery with a trans-sylvian exposure. Please just look at the left side of the screen. The whole key here is identification of the on-passage vessels, and that necessitates a wide opening of the sylvian fissure. Once this is done and you identify those vessels, you can identify the direct feeders to the nidus, and the surgery becomes less complicated as it looks like on the cerebral angiography. And you can see some part of the onyx inside the nidus, and all these sylvian AVM, this is a medial type according to Suzuki, extend both on the frontal and the temporal side. And here, by getting around, we just separate, identify the vessel that need to be disconnected. And this is the on-passage vessel you see here that was separated from the feeders. And these are the feeders coming from that major MCA going directly to the nidus. Some of them are clipped, some of them are coagulated, depending on how I feel which one is better to be clipped. Obviously, we avoid to put too many clips, but if it's needed, it is needed. And that's another last feeder here that we get under control and get on the temporal side of the nidus and eventually cut the draining vein, and this was basically the nidus coming out here.
And 3 minutes. Three minutes.
This patient did very well after surgery with no neurological deficit and discharged day 6. I like these contralateral exposures because that will give you a good exposure on the lateral aspect of the AVM. And we published on that a couple of years ago on a series of this patient that I had treated. This is a callosal parietal deep AVM with deep drainage vein into the vein of Gallian. And you can see here by opening to the falx and coming from the contralateral, you get to the contralateral parietal lobe. And then it's a matter of just working around the AVM nidus. It will give you very good oblique access to the lateral aspect of the nidus. This is the lateral aspect that you will get in a retractor-less fashion, as opposed to if you come from the ipsilateral side. And then you have access to feeders at the deep part coming from the PCA, those feeders that could not be embolized. And this is the final arterial feeders to the nidus. And this is give you a very good exposure with good control and resection of this deep AVM that is in a critical location. And again, this patient did very well, had a foot drop after surgery for a couple of months, but after that it improved. That was a 19-year-old patient with good neurological function eventually. And finally, the last thing I want to show you is management of intraoperative bleeding. This is a patient with a recent patient, large complex AVM that was partially embolized during the surgery. You can see here that this kind of bleeding can happen. So we are dissecting, feel things are going well, this AVM, very high flow, but you get into a significant bleeding here. The best way to control is to get a larger suction and don't hide the bleeding. Try to identify where is the bleeding and use clip if needed and control it. And another event of intraoperative bleeding here, you can see that that can happen with a rupture of another feeder just close to the draining vein. The most important thing here is to have a large suction, no packing, let it bleed out. And you're able to get this AVM out, and this will be with no consequences if it's dealt with this technique. So overall, I think these are the key to avoid a surgery complication. You can read by yourself, but I think the most important thing is to avoid intraoperative high blood pressure, stay outside the AVM, careful skeletalization of deep white matter feeders, and never hide the feeder, explore the ependymal surface of the AVM, and use intraoperative angiography. Some AVMs, I think, should never or not be operated on, ideally the grade 5 unruptured, most grade 4 unruptured. Some grade 3, depending on if the risk outweighs the benefits. Brainstem Avm and most thalamic Avm, they do not do well if they're especially unruptured and we try to treat them with surgery. This is my experience over the past years of practice that I have had, or until June of that past year. This series that we have collected with different locations that you can see, and the characteristic of this AVM, a little bit more in favor of unruptured, but pretty even. And these are the results of our multimodality treatment. So these are the patients that I have treated, and vast majority had preoperative embolization. And this results in new deficit post-op. And these are only new deficits. These are not the deficit that the patient had in case they had a hemorrhage or something. So 11% and 16% in each arm, new deficit caused by the treatment that I have done, embo plus surgery. And some of them, fortunately, were temporary and transient, and some of them were persistent. Two mortality, both in the hemorrhagic group, and residual AVM, a pretty low number. And fortunately, the residual number decreased since I'm using the angio suite for intraoperative angiogram because of the very high quality of the pictures that we can get. And if there is something, we go after and we try to really minimize the risk of residual AVM after surgery. So the controversy continues. I think the treatment of brain AVM should be individualized based on initial presentation, based on AVM characteristic, interventional risk assessment compared to natural history, and also the surgical expertise of a given tertiary experience center. And I do believe that treatment of unruptured AVM in experience center might have a better outcome and result than observation alone. And thanks again for giving me the opportunity.
Amir, thank you very much. Wonderful. As people who come to our sessions know, we usually keep the questions till after all the speakers have spoken. I remind the audience in the Q&A box in the bottom right of the Zoom thing, please put in all your questions, and I promise you we will read them at the end, but not until all the speakers have spoken. Gary, let's hear about Eloquent. Careful, we can see your emails, Gary.
Don't share those.
Don't worry, we'll delete it from the Iggy. Make sure, please, we delete this from the recording.
No, that's okay. Let's see. How am I sharing here? Screen sharing.
No worries, I'll edit it out.
Can you see my slides?
Yes, but put it in the yeah, perfect. That's it.
Great. So first, Jacques, I wanted to thank you for organizing this. You have done an incredible job with these symposium. I see more than 100 people on here. This was one of the benefits of COVID. We started with this when we couldn't meet live, but it has continued, and I think this is a great way to reach a large audience. So thank you for your work and your colleagues' work in that respect. I agree, Amir, I really enjoyed your talk, and I always learn something from these, and I agree with much of what you have to say, with a few exceptions. So these are my disclosures, and I did a fellowship with Charlie Drake back in for some of you, the Middle Ages, and Dr. Drake was known as a pioneer of basilar artery aneurysm surgery, but he also was a master AVM surgeon. In fact, I remember operating with him once on a tough AVM, and he said to me, and this of course was prior to embolization, prior to radiosurgery, and he said, Gary, AVMs are the toughest surgery. And I agree with that still, because they can be, if they get out of control, they can be very, very difficult, and they're very tedious. But he said back in 1979, surgical treatment will remain the procedure of choice for many, if not most AVMs, and I still agree with that in many respects. And then he talked about the story of the stuck catheters and errant glue. We usually don't glue catheters anymore. Occasionally we do that, but endovascular has really improved our ability to successfully treat patients. These are the eloquent areas, which Amir mentioned, that we didn't used to operate in, but we do now. And here's my series of AVMs. We've, since I started, 1,500 of them, 800 surgeries, and more than 75% of these are combinations using multimodality therapy. And we believed in this back in the 80s and have continued to believe in this. Here's a patient I treated a while ago with a basal ganglia bleed from this AVM. And you wonder, should you resect this in the basal ganglia? She made a complete recovery, but it's really pretty straightforward, especially if you work through the clot. I let the clot resolve, did not even embolize this. And then you can work around the AVM in the clot cavity. And it's really a straightforward matter to take out these relatively small, compact AVMs like that. Here's a more recent patient, a 34-year-old with headaches and visual changes. To confrontation, her visual fields were normal, but look at the visual field testing. She's got an incomplete left homonymous hemianopsia. And here's the AVM, and you can see it's a small atrial AVM. And the initial inclination would be to come in temporally, because that's a straight shot, but her visual fibers are here. And despite her partial visual field deficit, sometimes these patients can recover. Here's what it looks like. This is a compact AVM. You can see the supply from anterior and posterior circulation with deep venous drainage. And I decided, by the way, I also believe in using this virtual reality and sometimes AR. This is really advanced the way we can safely resect these and approach these lesions, looking at the fiber tracts and functional MR in ways we could not before. And so I decided to come in from a posterior superior parietal lobule to avoid the optic radiations completely, and did this through a small opening. Here's the approach. And here you are, you can see we're in the ventricle now. Here are some vessels feeding the AVM, working through a small opening, taking the feeders. And I like these clips too. I use these micro AVM clips. Here's a feeder coming off the posterior cerebral artery, which you want to preserve. And these clips are smaller, and that's a wet clip I put on the vein. And taking out the AVM, and did it through about a 1 centimeter opening. She did well, was discharged home on the 3rd postoperative day. You can see I gave her a complete left homonymous hemianopsia, but the remarkable thing is within 4 months, her visual fields were actually better than pre-op, and 22 months later, I saw her recently, normal visual fields. So don't be deceived by patients who have some visual field problem. It doesn't mean that those fibers are irreversibly injured. We had the good fortune of having a couple donate money for our virtual reality center. This is surgical theater, which I like. You can see, you can define the functional areas and the fiber tracts. And again, this is great for not only teaching patients, teaching residents, but we have this in the operating room. You can rehearse cases ahead of time. Here's functional MR overlaid. You can see a small Sylvian AVM, the associated hematoma fiber tracts, which are not located near it, but the tongue area, when we do functional MR, was located somewhat near it. So I think a real advance in terms of what we can do surgically. This is a little more difficult. This was a patient who had a hemorrhage from this Sylvian AVM in the, and really an insular AVM in the dominant hemisphere. And this was the first patient I decided to do awake. I'll operate on CAV-MALs with patients awake in this area, but not usually AVMs, but this worked out well. This one is diffuse. I also prefer the Spetzler-Martin grading system because it's simple. I don't use other grading systems, but I do take into account diffuseness, and also the age of the patient is one of the most critical factors. But this was a small one. Approach this, and we did not embolize it, but you can see there's no motor fibers near it, but there are some language areas on the operculum, not directly over the AVM. So I thought we could do this safely. And here you can see at surgery, she's 7 weeks post-bleed, had a mild aphasia and mild weakness at this point. And she talked to us the whole case, opening the fissure, She was a car enthusiast, had bought lots of Mustangs she was describing. Here's Sylvian vein. So you want to gain a wide exposure of the fissure. Spread the operculum. There's a M2 branch. Again, navigation is critical for this. And now we're going to stimulate in the region of the insula that we want to enter. And that was a safe area. So we make a little peel incision. This is an M2 branch. And this was a diffuse AVM, but small. So usually they're not a problem. And you see we're working anterior to the hemorrhage. And going around the AVM, taking the feeders one by one, as Amir showed. I buzz them till they're occluded, and then another 10 times to make sure they're obliterated. And this was a learning case for me because the resection went fine. She spoke to us the whole time, no deficits neurologically, took out the AVM, but I was not happy with the way this M2 branch looked right here. And I didn't think there was good flow in this. And so I temporarily occluded the M1 and the distal M2. I opened it up. Good flow proximally, but not good back bleeding from distal. So I attempted to restore flow. First, I put a probe in, then I irrigated with heparinized saline and managed to restore flow finally with a small wire. And then sewed that closed, sutured it with a Tenno suture, and was able to restore flow in that vessel, but not this inferior M2 branch. And we did an intra-op. We did this in the hybrid room, did an intra-op, which looked good, although it was missing the inferior branch. And I thought about doing a bypass to that branch, but she did not change neurologically. So I left her alone. And she was discharged after about a week and a half. And 2 months later, she's neurologically normal. But I just wanted to show you a way of getting out of trouble if you have a problem like that. This person also had an eloquent AVM in the Broca's area is where it mapped out to. It's a Spencer Martin 3. We embolized him twice. It's a compact AVM. And then this was another one that I decided to do with him awake, and we tested him the whole time. There's a little hemorrhage after the embolization, you can see. He presented with a seizure initially. And you can see going around the AVM. And now we mapped out his language area. And what you'll see is that was an eloquent area right there. So that stopped his speech, but this did not. The AVM is under here. So we had to be very careful with this aspect posterior to the vein. Now, I often will try to follow the vein down to the AVM. And in this case, I got into the vein a little. So there, you don't want to take the vein, tamponade it, and it'll usually stop without occluding it completely. Here, the vein's still filling. And then work around it. Now, the question is that a feeder or is that at the MCA? So we determined this was a feeding artery going right into the AVM. Stimulated again, his speech was still intact. And then finally clipping, and I like these AVM clips, these micro AVM clips rather than the Sunt micro clips. I use a wet clip for the vein, and then good resection. We do an ICG, but I don't think ICG is good enough for the deep portions of an AVM. So I always do either an intraoperative or postoperative angiogram. this patient had a non-dominant AVM with a hemorrhage, but it's very close. It's a Sylvian AVM, and it approaches the corona radiata. So I thought it was an eloquent area. We embolized him once, good embolization. It's a compact AVM, which is an advantage. What I wanted to show you here was the use of the flow meter that Fatty Charbel developed, because it is not only quantitative, but directional. So here's the AVM on the surface and opening the Sylvian fissure. Now, I didn't know if this was a feeding artery or a draining vein, but the directional flow meter told me this was actually a vein. And so I left it alone. I think that can be very useful. And then clipping, again, I like to clip the feeders, the large feeders, or the ones in the white matter that don't take a charge well. I clip these when they're coming off an MCA branch instead of buzzing it, so that you don't injure the MCA itself. And then working around it. And here you can see, again, feeder to the AVM. But you must leave the MCA en passage branches and the main MCA alone. There's the MCA. You can see a clip on one of the feeders coming off it going to the AVM. And we do an ICG, but again, I like to do I always do an angiogram afterwards. This is a little more challenging. This was a similar to a case that Amir showed. This was a 27-year-old woman with a frontal corpus callosum, and we thought partially hypothalamic AVM. She was embolized by Grant Hayashima when he was at UCLA when she was 6 years old in 1989. We don't know what happened after that, except she presented at 27 years old with a seizure. And what would you guys do with that? I didn't see her then, but I probably would have watched her. I mean, she made it, 21 years without a problem, neurologic, very high level functioning. And she was not treated then. However, she presented again 3 years later, and now she bled from this AVM. So after her hemorrhage, she was treated, and this was done at NYU, and I think it's appropriate. She was embolized and then treated with Gamma knife. And then she moved out here to the area I live, and she bled twice more. This is her third bleed, 5 and 9 months after embolization and radiosurgery. You can still see extensive AVM in corpus callosum and maybe hypothalamic area. I was worried about this, but I decided to operate. We did it in our hybrid OR room, which I think is a huge advantage. I like both these Codman irrigating bipolars and the Spetzler Malus, which Spetzler originally advertised as not needing irrigation because they were so non-stick, but now they're pushing the irrigating, and I like the irrigating version better. These were great micro AVM clips, but they were discontinued by Codman, and so I use these Sunt micro AVM clips with a modified applier, which is shorter. And I'll show you how I use it. So this is coming around the AVM, and pretty straightforward, but now you get into this deep white matter feeding problem, and they will not take a charge, but one clip will seal that vessel, and it can save you hours of time. So take advantage, as Amir showed you also, of these AVM clips. And there you can see some of those clips in there. And she did well 1 week post-op. She remained neurologically normal. The grade 4 and 5 AVMs, I think, are very challenging. Worse natural history than grade 1 to 3, higher bleed rate, increased morbidity and mortality when they bleed. Radiosurgery is not nearly as good at curing these and has a higher complication rate than with the lower grade AVMs. Here's someone I saw a number of years ago who had bled 3 times from this AVM. He was treated at Harvard by Gelberg with proton beam radiosurgery. 9 years later, had a 4th bleed with weakness. And here's what the AVM looked like. No change in terms of the angiographic appearance. A diffuse grade 5. We embolized him 4 times and did give him a new visual field deficit. And then I operated, and I staged this 1 to 2 weeks apart. First, I approached it interhemispheric transcallosal. And here you see going through the corpus callosum. And what I found was, despite the angiographic appearance, even in non-embolized areas, this was a simple AVM to take out. Very little bleeding, which surprised me because the angiogram looked so horrible. And after taking out this, this one component, transcallosal interhemispheric, I came back 1 to 2 weeks later and then approached it frontally transcortically, and then another 10 days later, parietal transcortical, and we cured him. Did give him some new leg weakness, which resolved after 4 months. But what I found with this and another 94 patients was that after radiosurgery, the AVM vessels are thicker, they're easier to coagulate, much easier to resect. The small vessel of the AVM is obliterated. It's almost like a fistula. And now I tend to think of, and we just published this year, we try to think of radiosurgery sometimes as a pre-microsurgical adjunct. And I explain that to the patients and families, but you have to be patient. This is years later when we come back. Stage surgery, I don't know if any of you use stage surgery. Many cerebrovascular surgeons frown on this, and I don't know why, because we stage embolization all the time to allow the brain to adjust hemodynamically. And I've done this in 22 patients, because I did one recently, mostly grade 3 to 5 AVMs, larger size. I plan to do this in half the patients almost. The other half I decided at surgery because of refractory bleeding from the deep white matter or new bleeding from areas of brain that were completely dry before. And I think this is a good approach in some cases. Here's another AVM that was, we radiated actually with helium ion on the cyclotron here at, in our combined Berkeley-Stanford program, 25-year-old, and no change 3 years later. This is a relatively low dose, but you have to be careful with higher doses in these large AVMs. Post-embolization, still significant AVM. At surgery, we mapped them out, and fortunately, the motor sensory area was located here where this grid is in front of the vein. This is the AVM posterior to it. I resected it, and remarkably, all he had was a foot drop that resolved after 5 months. Here he is 29 years later. And so again, I think that consider coming back after incomplete obliteration of these AVMs. Even though they can still look horrible, they are easy AVMs. Here's one that I learned something from. This patient, young
Gary, one or 2 minutes, if you don't mind. Thanks.
Yes. Here's a patient who had radiosurgery. I resected it in the thalamus. Woke up fine. 2 days later, new left hemiparesis. And you see what's happened is this vein, the draining vein, has clotted off. Here was what it looked like pre-op, post-op. It's gone, collateral drainage. So this is where I started avoiding volume depletion in these patients, and I keep them normovolemic. Going to end on brainstem AVMs, because I think these can and should be resected at times. Here's a medullary AVM. I won't go into how I approach it. I actually do these through a midline incision now, prone concord position. And here you can see the draining vein arterialized. And here's the stem. And this was mostly on the peel surface and in the cistern. And this is why I think these can be resected. And I won't show you the whole thing, but taking it out was pretty straightforward. The last case I'm going to show is a midbrain AVM in a patient who bled, not sure if it was the aneurysm associated. We coiled that and then approached this transpetrous subtemporal. And with these brainstem AVMs, you don't have to actually resect them. You can obliterate them. Here's the fourth nerve, by the way. This is subtemporal. And what I did here was to obliterate the AVM in situ by coagulating the feeders and as much AVM as possible. And that resulted in a cure, actually. So brainstem AVMs, they should often be considered for surgery. 90% of these patients who had surgery were cured, only a quarter if they didn't have surgery. And they often present with hemorrhage. The majority were peel, and that's why I think you can resect them. Surgery is the best chance of cure. And I want to thank my team, some of whom I've worked with for more than 30 years. And again, thank you for your attention. Appreciate everyone listening today. Thank you.
Thanks, Gary, for this fantastic collection and presentation of really challenging AVMs. And last but not least, Adam, I guess you've heard the first two speakers seem to be lovers of embolization. Are they correct in that? Set us straight. What do you think is the role of embolization in AVMs? Thanks a lot.
Pleasure. Well, you know, we lost 1 million people with COVID, and the labor market was disrupted horrifically, and I think it exposed some horrible weaknesses in our healthcare system and undervaluing of what nurses do. But there is a silver lining, and on a Thursday night, you know, before a faculty dinner, getting to spend this time with you guys is really something that just didn't exist before COVID. So I'm grateful for that. I knew, because I know and respect Gary and Amir very much, that their talks would focus on the craftsmanship of AVM resection. And so I'm going to stay away from that, even though I love that topic too. Most of you know about AVMs and what they are, what the pathology is. Gary, like Michael Lawton, pointed out that this histopathology can be changed beneficially by radiosurgery and can make surgery actually much easier. The seizures and headaches that present, you know, we used to think that that was arterial steel, and I think more and more evidence is clear that that's not the case. I'm coming to believe, and I call this lore because I think this is something that we're making up as we go along based on a lot of different lines of evidence, that AVMs are really deceptive. They're not a focal localized lesion like a tumor. They are a flow derangement that causes progressive changes to the entire cerebral venous system. They're really a venous problem. And I think that systemic venous effect is why they present with seizures, why they present with headache, why they rupture into the ventricles. And understanding the AVM and its relationship to surrounding structures is something that you see very keenly developed by the best AVM doctors. And it's something that I think anyone who's interested in treating these should really spend some time on. Obviously, you always have lots of options, and I'm going to go over what's in the literature. And, you know, what we see is a lot of self-adjudicated retrospective case series. The best of these is Neil Martin and Robert Spetzler's, because what they did with their retrospective case series is they tried to come up with an organized way to look at risk. And with the supplementary grading scale that Mike Lawton came along with, that remains an awfully good way of trying to organize your thoughts on the operative selection and treatment of AVMs with surgery. There's plenty of retrospective case series on AVM risks, on radiosurgery, and on embolization. Gary Duckweiler was an early pioneer in getting pre-market approval of Onyx for the treatment of AVM, and essentially just showing for pre-treatment of AVM with surgery, Onyx is no worse than glue. And then there are retrospective case series now from Europe, the Turks, the French. They really believe in curative embolization of AVMs, starting transarterially, getting into the vein eventually. And qualitatively, what I'll say is, I don't think that what they're doing in terms of the evidence for that treatment is any different than what the surgeons have done. Obviously, there are major disagreements about what's right, but I've seen an awful lot of very good treatments of AVM with embolization alone, even though it's not something that I do often in Memphis. Aruba was mentioned by Amir. Amir, I'm going to quibble. You know, you mentioned Aruba and criticized it, and then immediately responded with a retrospective single center self-adjudicated case series from Harvard. And I just think that you're comparing apples and oranges. I don't love Aruba because I think studying a long-term disease in 5 years has complications and problems that we all knew were coming. Many of us didn't participate for this reason. But that doesn't mean that there wasn't good stuff to be learned from Aruba. And one of the things that I don't think we've really internalized all over is that partial embolization of AVMs is a bad idea. And yet I still see that. I see that all over the country. I bet you see it much more in the New York area and in the Miami area than I see in the Mid-South, and probably in California too. We don't seem to have internalized what I think is actually an important lesson from Aruba, which is that half treatment or partial treatment with embolization is much worse than leaving the AVM alone. I was asked to look at a case recently where a neurointerventionalist neurosurgeon embolized a young woman with an unruptured AVM 11 separate times, predictably resulting eventually in a severe complication for an AVM that could easily have been resected, a grade 1 on the surface. Not evidence-based, but it's happening in our country. Aruba, of course, was not a study of the surgical treatment of AVMs. That's been pointed out many, many times. You can't use it to say we shouldn't operate on AVMs, but that is what's kind of happening in the United States, at least. So I won't go into this at great length. I don't love the design of the trial, and I do think the results, while interesting, have been broadly misconstrued. Bobby and the Miami's group had a recent paper that I think Amir mentioned on the national inpatient sample, looking at what Aruba has done to us in terms of how we treat AVMs. And there are more patients now presenting with incidentally discovered AVMs because there's more neuroimaging. Bobby's national inpatient sample paper indicated that that's resulting in more AVM ruptures. There's a contrasting paper from Giuseppe and the group at Mayo that says that that's not true. I don't know, and I don't trust national inpatient sample papers, even though I love both Giuseppe's group and your group there, Jacques. I just think that qualitative administrative databases are not really great levels of evidence. What I will say is that there's more than just Aruba that affects the behavior of cerebrovascular neurosurgeons and interventionalists. And we've seen a dramatic growth in very disorganized training of neurointerventionalists in the United States. And these guys that we're justifying because they need to do thrombectomies have got to have something to do with their daytime work, and they're going after AVMs, even though I think that's the one conclusion from Aruba that we absolutely could learn. So what we're seeing is a lot of self-adjudicated retrospective case series showing that AVMs can be treated alone. They can be treated with combination. We're seeing that Onyx works well as NBCA, and we're seeing more AVMs diagnosed before rupture. There's been absolutely no decrease in the interventional embolization treatment of AVMs after Aruba, which there should have been, but there has been a decrease in the microsurgical treatment of AVMs after Aruba, which I don't think there should have been. So we seem to be learning the wrong lessons from the evidence that we have. So because I was asked to talk about embolization, I'm going to go over some basic information on it that I think is still interesting. NBCA glue is still used and still on label for the use for the preoperative embolization AVMs, and it has some advantages. It cooks the vessels. When glue goes in, it really is exothermic. And that release of heat means that a glued vessel is really glued. Gary mentioned glued catheters. We've been there, trying to avoid that. But it can be very useful, particularly for fistulous components of AVM. It's a little harder, but it really does sort of batten down the hatches of the vessels. It strips the endothelium, it's hot, and it's mechanical. Early response is inflammation, late response is angiofibrosis. Onyx, or ethyl vinyl copolymer, was originally designed to be a food preservative membrane. And so what Onyx does is it doesn't interact with the tissue. It doesn't cook the tissue. It just stretches the vessels. It just fills the vessels. And this is why Amir pointed out that sometimes you'll go in the OR and deal with an Onyx vessel and find there's still flow in it, because all it's going to do is stretch and fill the vessel, and it's very easy for blood to get by it. Now, you get enough of it into an AVM, you can cure an AVM with it for sure, but it's not going to be just going after the artery, although it can be very useful to go after arteries. With either Onyx or with glue, you really have to make, I think, an informed decision using it in a way that makes sense for preoperative resection. Jacques knows this because he's been through it. If you have radiologists and neurosurgeons who talk to each other, and the radiologist is just trying to pump as much Onyx or glue into the AVM as possible, that's not good. The AVM becomes very stiff. And often they go after the feeders that we can get very easily in the operating room. I think ideally we have comprehensively trained surgeons who are using embolization as a part of the surgery. Jacques just finished training a young attending in my group, Nick Kahn, and I think Nick has got every opportunity to become as good or better a microsurgeon as any of us, but he's going to be able to integrate embolization into what he does with AVMs. Onyx polymerizes, it flows like lava, and it's in it's an ethyl vinyl copolymer that's in DMSO. Early immediate response is similar endothelial stripping, although it doesn't cook the vessels, and you get different responses based on how fast you inject it. A faster injection is more toxic and causes more mural angionecrosis. So I'm going to present a brief case. I think I presented this the last time we talked about AVMs at the Miami Symposium. This guy's an English graduate student who started talking gibberish, more gibberish than the usual English graduate student, in my opinion. His girlfriend called 911, and he has an expressive aphasia and a very localized hemorrhage with a very localized AVM. Now, this could be resected with embolization. There's no question. And I wouldn't bark at you if you wanted to do that. But in our shop, as Gary mentioned, we really are quite keen on using embolization to make surgery safe and easy. So here you see not a curative embolization, not a ton of onyx, but a takedown of a portion of the AVM. There's still little enough onyx that you're going to be able to compress and move the nidus around. And surgery in this case is relatively easy in a very eloquent area. We often will operate early on AVMs. I don't think for an English graduate student having to go through speech pathology and rehab twice is a good thing. And I don't see a real benefit to waiting months and months and months. So we treated him with embolization and resection at the same time, and he made a very good recovery. That slide shouldn't be in there. Sorry, I was just going to talk about eloquence. This is Dan Barrow's good, bad, and ugly. These are all features that increase rupture risk. Obviously, offering to treat an unruptured AVM, and Amir mentioned this is where the controversy is an art, not a science. And so for young patients, you have to think about these factors, and you have to think about what that AVM is going to do to the venous system over decades and weigh that against the risk of surgery. And that kind of decision process is what we missed with Aruba, the decades-long destructive treatment of an AVM on the venous system versus the risks you're going to have at hopefully a high-volume center where you're really very thoughtful and logical about how you use embolization in conjunction with surgery or radiosurgery. So here's a patient that I did treat with curative embolization, and I do have long-term follow-up. I treated this guy 15 years ago. He's the mayor of a small town in Mississippi, or a medium town in Mississippi, and he'd already been seen at another academic medical center. He had a ruptured AVM that really was right in his motor strip. He'd had some arm weakness that had gotten better, but I would argue that this could be resected right out of his motor strip. Craftsmen like you can probably do that with a low risk of a permanent deficit. But this is where I think the French have some good thoughts. Here you see microcatheter injections from a microcatheter that's all the way up in the nidus. And we have much better treatment options now than we did then. We can use microballoons like the Scepter Mini. In this case, I used a second catheter to form a backboard to allow me to perfuse into this AVM. So there's this little bit of Onyx 34 to give you a back push so you only go forward. And then here's the injection of the Onyx in the now slowed AVM. And then here is an attempt at curative embolization. I wanted to avoid operating in his motor strip. I'm not saying you can't do it. I'm just saying I thought we could cure this guy. It's a very focal small AVM, and we pushed, in this case, Onyx all the way into the vein. We got a curative result. Here you see some slow vessels and a little bit of hypervascularity around the AVM. I think it's difficult sometimes to know what truly is nidus because they do create sort of local hypervascularity. But we followed this guy. This is his 1 month. We followed him for 15 years, and he's had absolutely no recurrence and didn't have to have a surgery in his motor strip. This is one of a small handful of curative embolizations I've pursued at our center. We're really a surgery first outfit, but I think there is a lot that can be learned as far as this as a modality. So I wanted to finish early, knowing that the discussion is always the best part of these Zoomposia. Where does this leave us? How do we digest what we learned from Aruba? I don't think we've done that well. And when should we use embolization as an adjunct to surgery or radiosurgery? And when or if should we ever consider it as a curative standalone therapy? As I said, I know at Bicêtre in Paris, there's essentially no AVM resections going on. Their view and their friends is that we're primitive to continue to take them out. I know at my center, we mostly do surgery, but we still sometimes use embolization, sometimes use radiosurgery, and in a handful of cases, we'll use curative embolization. I know that at Jacques' center, there's probably less embolization, less aggressive embolization. How do you make the decisions? Well, this is the patient that we saw yesterday in my multidisciplinary conference, and so I thought it was interesting to share. He's a 34-year-old. Ideally, he's got decades and decades of life in front of him. He's never had a rupture. He's got an AVM that's clearly in an eloquent area on the left side of his brain into the motor strip, and he has seizures that are now well controlled on Keppra. Here's the AVM. It's a grade 3 or 4. Supplementary grade is reasonably high. I think there's some diffuseness to it. And actually diffuseness rather than size alone is one of the things that backs me up a little bit as a surgeon because of all that eloquent tissue around that. There's not supposed to be any intervening brain tissue in AVMs, but that's not always been my experience in the operating room. I think this is a patient who might be given lots of different recommendations at lots of different centers. Luckily, he's got a phenomenal doctor and my partner, Dan Hoyt, and Dan will talk to him about what to recommend. But I think that this is the kind of patient who might be offered a curative embolization in some centers, might be offered a resection without embolization in the others, might be offered embolization and then radiosurgery in still others, and might be offered radiosurgery alone with a multicentric plan, multifocal plan at lots of different centers. So where is embolization in the role of the treatment of AVMs? Well, it's all over the damn place. We haven't paid good attention to what the evidence has shown us. I will state unequivocally that just embolization without careful thought to the anatomy and embolization and embolization and embolization again, I've heard very respected colleagues advocate a planless progressive embolization until you decide you're going to do radiosurgery or surgery. I think that is dead wrong. I, on the contrary, believe that embolization as a thoughtful, logical, anatomically based adjunct to lowering the size of the field for radiosurgery or improve the safety of surgery is very well proven by the literature. And I would also argue that there are some cases where experienced centers can employ curative embolization with the admission that the evidence for that at this point is at best single center self-adjudicated case series, and then bad news from Aruba that there can be a lot of risks when that's done at a lot of different centers. So those are my conclusions. I will admit I don't know everything about this, but I'll also admit that I think AVMs are one of the most fascinating diseases I've ever come across. I love dealing with AVMs, but I think the first thing is to really carefully analyze the vascular anatomy, the neuroanatomy. I love the augmented reality and the virtual reality toys that you guys showed. I think those are fantastic and probably very helpful in looking at how we treat them. And then considering the patient as a whole in terms of how old they are, what other illnesses they have. I trained under Bill Caldwell and we never saw an AVM that we didn't resect. And then I moved here and there was a phenomenal old surgeon in Memphis named Morris Ray, who was very conservative, and he beat the crap out of me. He would bring films into my clinic every week and say, "What do you want to do with this, Adam?" And I'd talk about how I was going to take it out. And he'd say, "Yeah, the film's 10 years old and she's fine." And then he'd walk away. And when he retired, he left all his AVM patients to me. So I became a lot more conservative by force because all these conservative AVMs ended up in my clinic. But I love talking about them. I love seeing your presentations, and I'll look forward to the discussion to follow. Thank you very much.
That's spectacular, Adam. Thank you so much. I will give myself a pat on the back for my good taste in selecting speakers, and you guys can see. You guys can see the audience what spectacular panel we have. Okay, so let's tackle the questions of the audience. There are about 6 or 7. First, Alim Bayramov. His question to Amir. What is advantage and disadvantage of microsurgical resection and stereotactic radiotherapy for the treatment of AVM, and which complications can occur after them? It's a very wide question. Maybe you can briefly summarize your thoughts, Amir.
I think AVM remains a surgical lesion, as I tried to allude to, and the best treatment for AVM, to answer simply this complex question, the best treatment for AVM is surgery. And the best treatment for AVM is surgery until proven otherwise, based on patient's characteristics, AVM location, and so on. If we feel that surgery has unacceptable upfront risk, specifically for unruptured AVM, then we'll think about other modalities. And in line will come that, okay, can we do the surgery safer with preoperative embolization? If yes, then do it. And if the surgery is not safe for whatever reason, then we will think about stereotactic radiosurgery. Unfortunately, stereotactic radiosurgery has made a change in the treatment paradigm in such that very often I hear that SRS becomes as the first choice for treatment of AVM, which I don't agree with. Again, we can't answer this question with 1 or 2 simple sentences, but I think the major answer to this question, the advantage of surgery is immediate cure, and it's the best treatment in well-selected patients. That's how I frame it.
Okay, let me read mostly a comment by Ahmad Atasi. He liked your talk, and he's commenting that yes, onyx injected intraarterially does not occlude the lumen. This is one important reason why transvenous embolization is more logical treatment. Add to that AVM is parenchymal disease. From an endovascular point of view, embolizing the artery alone does not treat the AVM. Adam, I don't know if you heard my whole read of his comment. Do you agree with his comment? This is Ahmad Atasi.
Well, I think what Ahmad is saying is, in a way, something I like, in that it's not just an arterial disease. And so he's pointing out that only putting onyx in that artery doesn't occlude it. And that if you want to really occlude the AVM, you're going to have to get to the vein, either transvenous or transarterial into the vein. The part I disagree with is, that it's quote unquote a parenchymal disease. As I said, I think it's a parenchymal manifestation of a derangement of the venous system, and that's where the real, rubber hits the road. But yeah, I mentioned in my talk, Amir's showing the blood flowing in that onyx vessel. I've seen that. I'm sure you've seen that, and I think that's what Ahmed is mentioning.
Great. A question from Dulanka Silva. I addressed to Amir, but maybe I can get Gary also to answer. I would like to ask a query about timing of microsurgical excision following embolization in those AVMs one treats in a multimodality fashion. Most of the cases I have done in our center, we embolize and operate 1 to 2 days following embolization. So far, we have only done 1 pre-op embo and proceeded. If one is doing 2 pre-op embo sessions, what is your time of surgery, the timing of surgery following embo? Amir and then Gary.
If we do a multiple session, usually we space them by 4 weeks, and that also has some degree of organizational concern that you don't want the readmission, stuff like that, to be considered. But usually the sessions we divide by 2-3 weeks at least in between, if it's a 2 or 3 session embolization, and we'll leave the last and most important part of the embolization for the last part, the day before the surgery. And sometimes if I feel that embolization has helped a lot or changed dramatically the AVM flow, we keep the patient intubated, sedated even, sometimes if necessary, with low blood pressure in the ICU with the plan for surgery the day after. This doesn't happen often. This is rare. But that's how we do it. Usually 1 session embo will be the day before the surgery.
Gary?
Yeah, we have a little different approach. I mean, I have operated a day or two after embolization, and what usually you see is the brain is inflamed. There are little micro strokes. We've seen this on MR scan. I think with embolization, you often get some injury. And so we've been doing this for 30 years now, we embolize not more than 25 to 30% of an AVM at any one session. And we space the embolizations a week apart. And that makes sense because the whole idea of the embolization is to allow the brain to adjust to the hemodynamics, not just to cut down the volume. And likewise, I don't operate unless, patients bleed for a week after at least a week after the prior embolization. So I like to let the brain relax. I like to let the embolization have the full effect of allowing hemodynamics to normalize. And we've been very successful in doing it that way.
Bobby, I don't know, do you want to comment on this question, the timing of surgery following embolization? You obviously do both, and what do you think?
Yeah, I mean, usually, a lot of times if it's a straightforward embolization and it only needs one embolization, we do it the day before. For some of the giant AVMs, sometimes we'll space them out. Going back a long ways, we used more particles, and we even used some silk sutures and things like that. So, the more temporary things like particles, we probably wouldn't want to go more than 2 to 3 weeks before the surgery.
Okay, coming back to Alim Bayramov, I guess he wants to ask you, Gary, what is the mechanism of pulsatile tinnitus from a dural AV malformation? I assume he's meaning dural AV fistula, but mechanism of pulsatile tinnitus.
Yeah, I think it's pretty straightforward. There's markedly increased flow to the brain through the large feeders, and that includes the carotid artery, which passes close to the cochlea, in the skull base. And so the increased flow is what causes the pulsatile tinnitus, actually. Sometimes it can be other vessels that are near the ear, and that's why you hear it. I think that's a good explanation.
Yeah, I agree. Also from Alim, and maybe I'll ask Adam and Bobby to answer this question. Adam, when do you use palliative AVM embolization? In which cases, and what do you believe could be complications?
I do not believe palliative embolization of AVMs is something that should be broadly used. As I mentioned, I think, you can't be partway pregnant, and I don't think there's such a thing as a partway embolized AVM. I think at high volume advanced centers, in rare cases, palliative treatment of the AVM with embolization can be used, but I really believe we need to be more of a community and send these cases to referral centers, because what I see often is sequential embolization of an AVM labeled palliative treatment of an otherwise inoperable AVM at a center that maybe treats fewer than 100 AVMs a year. And I think probably it's better for that patient to be referred to a center that has a little bit more experience.
Bobby, we've certainly used some palliative embolization in those monstrous grade 5 AVMs with intractable seizure status at our center. What would you want to comment some more?
Yeah, I agree completely. I mean, a lot of times we get these patients from elsewhere and the embolization makes no sense. I mean, we had that one young girl with a 7.5 centimeter AVM with a small amount of maybe like 0.5 centimeter embolic material right in the middle of the AVM. I don't know what role that has. We have one patient that she's got a whole hemispheric AVM, and every couple of years she comes back for palliative embolization. She develops right arm and leg weakness. That's pretty obvious, and it's not a curative AVM, but we can go in, We embolize it. Usually her weakness completely resolves. And, I tell her in a couple of years, it'll probably grow the branches back and you can come back then. The other ones that we commonly do palliative are the spinal AVMs. They're right in the middle of the spinal cord and they develop progressive symptoms. And the largest series out of Paris, they have a really nice article following these patients over 20 years. And they have a number of patients that come in for particle embolization every 1 to 3 years when they start developing symptoms. And they embolize, symptoms usually go away, but obviously they're going to come back down the road.
Gary, I actually was thinking of the same thing. Sally Price has an interesting question for you about awake surgery. Of course, we all do awake surgery for tumors. Several patients find the sylvian region and the insula to be most painful. How do you deal with that in AVM surgery?
I had trepidation in doing these cases awake, and I've done a few of these larger AVMs, but that hasn't seemed to be an issue. I think the key thing is your anesthesiologist, and we have a team led by Richard Jaffe, who I've worked with for more than 30 years, who are they're wizards at doing awake cases. So it's key to do local injections and blocks when you're putting on the frame and when you're doing the craniotomy. But we have not had, and then of course you give sedation enough so you can still examine the patient and have them talking to you, but not enough also that they're not feeling pain. We have not had a problem. Occasionally they'll say that's painful and we'll inject. So usually the pain is coming from the skin area and the pericranium, because as you all know, the brain doesn't have any pain fibers itself. So it has not been an issue with a good anesthesia group.
Yeah, I agree. Hi, Ziad Khatib, who's a colleague here in Miami. Hi, Ziad, is asking a very relevant question. I'll pose it to anybody who would like to answer it. Any role for targeted medical therapy based on molecular genomic testing of AVMs?
Absolutely. So I think among our cerebrovascular diseases, this is the one we may lose altogether to genetic therapy. There are early studies showing somatic mutations in MAP2K1, key signaling mechanisms. Again, this isn't cancer. This is a derangement of the venous drainage system. And I think that it might be within our lifetime that we find a way to treat AVMs with medicine that allows normal circulation to take over. We're not there yet, but it's an absolutely fascinating area of research, in my opinion. I don't know if the others disagree or not.
I'll comment because I came back. I went to a International Avm meeting. We've had this every 2 years, except for COVID, and the last one was in Val d'Isere, and it was tacked on to. Were you there? You weren't there, Adam, were you? Anyway, it's a great meeting. It's heavily dominated by endovascular folks, but there's a lot of basic research. And I would say we are already treating AVMs with medical therapy. Sirolimus is an mTOR inhibitor, and it is highly successful for facial AVMs and AVMs elsewhere in the body. And it is there are some early trials in Europe which show efficacy for brain AVMs. So it blocks important signaling pathways that are related to angiogenesis and vasculogenesis. Another one, which got a very bad name in the 50s, is thalidomide. Some of you may remember that. Thalidomide is an immunomodulatory drug, and it was used for in the 50s for treating pregnant women with nausea. And of course, we've seen those horrible pictures of birth defects with limb anomalies because it blocks development of blood vessels and limbs. But if it's used in the proper setting and it's been used for experimental AVMs in animals, it is also effective. In fact, we're thinking of trying it on some of our horrible AVMs. VEGF, we've tried on some AVMs and cerebral proliferative angiopathy. To tell you the truth, not with great success. But I think the future is very bright for some of these molecular therapies.
Yeah, I
There are
agree.
no
We
other
usually put
pathways.
them on the patients on sirolimus if they have, especially those giant facial AVMs. We just did one today, and
Mhm.
especially if they're repeating bleeding episodes from the nose, they usually come in for palliative embolization, and then we put them on sirolimus as well.
Amir, you want to say something?
Yeah, I had treated before and two patients with that, but I don't have follow-up on them. I don't know what happened to them. But there are two other pathways. One we published a few years ago on the upregulation of Notch3 proteins in AVM. So if we can work on a way to downregulate the Notch3 protein, that might help in the regression of AVM. And recently, the Toronto group showed the KRAS mutation in AVM, which is also another pathway. So there are lots of different way that one can potentially downregulate the brain AVM. And I think in 50 years from now, any treatment and medical would be considered probably a nonsense for AVM, but we are not there yet.
Okay, and for the last question from the audience, a topic actually we haven't quite, I don't think any of you has mentioned it, flow-related aneurysms in the unruptured AVM setting. To talk about your philosophy with that, compare your thoughts about treating them preemptively before treating the AVM, or perhaps waiting for them to disappear and regress following AVM resection. What are your thoughts? Maybe we'll do it by seniority. Gary, you go first.
I think,
Flow-related
yeah,
aneurysm.
no, we used to follow these when we started using radiosurgery back in the 80s. And sometimes when you obliterate the AVM, the feeding vessel aneurysms disappear, but sometimes they rupture as the AVM's clotting off. So we're very aggressive with treating them. Intranital aneurysms, I think, are critical to treat because they're often the cause of the hemorrhage. And feeding vessel aneurysms also, if they're should be treated. So we either treat them during embolization. In a ruptured AVM, we'll treat them endovascularly even before we embolize or take out the AVM. If we're just going to do surgery and there's an AVM and there's an aneurysm in the AVM or on a feeding vessel, we'll treat it at the time of surgery if we're not going to do embolization. But we're very aggressive in treating both intranital and feeding vessel aneurysms.
Anybody else wants to add anything?
Sure, I think it's something that can be taken on a case-by-case basis. I have embolized flow-related aneurysms in grade 5 AVMs that we weren't going to treat because the aneurysms were growing and we wanted to give the patient as much good quality of life as possible. I have taken out AVMs and watched the flow-related aneurysms go away or stabilize, and really small aneurysms that you were going to leave alone anyway. Or I've clipped flow-related aneurysms in conjunction with AVM resection. I think it all depends on how accessible it is, how big it is, and are you going to tackle the AVM. But I do think there's a huge difference between flow-related aneurysms and intranital aneurysms. Flow-related aneurysms usually are disparate, separate from the AVM, often occur at normal anatomical locations. And if you're going to remove the AVM, sometimes particularly the small blistery ones will stabilize and regress. Now, if it's a big one, or even a medium one, and you can treat it easily with a clip or an endovascular means, that's probably safer because, as Gary points out, the complexity of flow remodeling after an AVM is treated is not something that I think we can always predict.
Great, thanks.
Zach, I want to add to two quick things. One is that I think for prenatal aneurysms, the question comes if they are ruptured and if the source of rupture is the prenatal aneurysm and you secure that, let's say with embolization, how aggressive you will be with the AVM that has not ruptured, but there is a prenatal aneurysm that has caused the rupture. So that could be a question for the panel, and it's interesting to know how. I mean, most people probably would treat the AVM, but do we really know what's going to happen to the natural history of that AVM when the cause of rupture has been secured? And on the other side, I want to mention I have two patients in the last year or two with prenatal aneurysm that I treated for unruptured AVM in the deep or parietal, distal parietal region. and they're a prenatal aneurysm that was supposed to, as was said before, shrink or at least remain stable, actually grew in size after resection of the AVM. And I treat both of them with surgery. This was something that I was not expecting, but that also can happen, that despite the AVM treatment, the aneurysm grow in size, which is interesting.
I think, you know, the lovely science of CFD, computerized flow, is probably going to help us understand which aneurysms might grow, which ones might shrink. And I bet there is some size threshold below which they might shrink, or who knows, but certainly have seen it. Okay, why don't I invite Eva Wu? Eva, are you ready to show the first case?
Yeah.
And then after that, Matt will show the second case.
Let me just share my screen.
Hopefully your new computer will work today.
It works very well.
That's
So
right.
you can see my screen, right?
Yes.
Okay, so yeah, we actually picked this case. We thought it was would be an interesting one to present. And so this is a 61-year-old male who actually initially presented to ENT with 8 months of decreased hearing on the left, as well as tinnitus and then gait imbalance. And so on exam, you know, his face was symmetric. He fell to the right when ambulating, but otherwise he was intact. And on audiogram performed by ENT, his speech discrimination score was actually 70%. And otherwise he had no other like relevant past medical history. And so initially they got an MRI, and this is a T1 with contrast. And so it showed this IAC lesion, which they thought it was an acoustic. So they did another MRI with the KISS. And so it shows these like vascular flow voids going into the IAC. And so then subsequently CTA was done. And so later on, we did an angiogram. And so this is the lateral left ECA injection. And then we're going to ask the panelists after I show them the complete angiogram, what they think this lesion is. And then this is the AP left ECA injection. And then this is the AP left vertebral artery injection. And then this is the lateral left injection. And so just looking at this, we wanted to, you know, get our panelists' opinion to see, you know, what they think that this lesion would.
Amir, can you just help us understand this lesion?
I think definitely there is a dural fistulous component to it. It seems that is a neuromeningeal trunk of the ascending pharyngeal, giving branches to.
Eva, go back to what he is talking about. Go back so the audience can. Yeah,
right
that's
here.
what you're talking about.
And that it seems that it drains through what seems to be a subarachnoid vein, and then turns around the internal artery canal, and then eventually ends up in the, I assume, through the superior petrosal sinus to the transverse and sigmoid sinus. So that's the dural, that's the external part. But what is interesting that it seems that there is also a PL component to it, because we saw
from the ICA. Yeah, show them that. That's right.
But which I have seen that there is dual component to this PL fistula. I mean, it's not really, I'm not sure if it's a PL fistula, because it seems that based on that MRI, the abnormality was really in the IHC. So it was really a subarachnoid compartment and not really on the surface of the PIA. But I would say that this is a lesion that has both supply from internal and external, equivalent to a dural and PL AV fistula with a draining vein that is in a subarachnoid space, equivalent to what we call, and it's an anterior grade in the sinus, so the sinus is not occluded or anything, so equivalent to a Borden 3 or Cognac 3.
Gary, any different interpretation?
No, I agree. I initially thought this might be a more of a fistula than a true PL AVM, but there's definitely a supply from the ICA. And, you know, some of these lesions are PL and dural AVM, AV fistulas. They could be hybrid lesions. So,
You're mute. You're
you know,
muted.
sorry, can you hear me?
Yeah, now you're okay.
Yeah, no, I think it's a combination of a dural AVM and fistulous component. I don't think it's in the brain though. I think it's in the cistern. And
Well,
so,
in the IAC, here is the MRI.
Yeah.
See, there it is. Can you freeze it, Eva?
Oh yeah,
Just
let me just go to the KISS sequence real quick. I think it's better on the KISS. Here.
it's I mean, that's how it was discovered. It failed the IAC.
right. I wondered whether you think this could be treated endovascularly. You know, I mean, we often treat a first choice of cranial dural AVFs, see if that can be obliterated endovascularly, either from the arterial side or from the venous side.
Well, let's bring in Adam into the conversation. Adam.
Yeah, dural fistulas, PF fistulas, and AVMs are supposed to be separate categories, but patients are often lazy and they don't study and read the textbooks enough.
That's a good answer.
It's frustrating when they do this.
Yeah.
I usually, shake my finger at them in clinic. But I think there is shunting there. I think it does appear to be dural based and in the cistern more than intraparenchymal. And I would probably start with an asleep microcatheterization for two reasons. Number one, it's possible that you can get a microcatheter there, either out the ICA or up the neuromeningeal trunk, to a position where you can very slickly just embolize it. But in the absence of that, let's say you take a microcatheter out there and you say, oh, I think this is going to fill something that I don't want to embolize. You're going to really have a better view of the actual microvascular architecture of it with selective catheterization. So my move here, thinking that this is kind of a hybrid lesion, would be a diagnostic with the possibility of treatment microcatheterization to primarily learn more about it. And if it's low-hanging fruit, go ahead and take it endovascularly. If it's not, and you microcatheterize it and you don't feel up to it, I think this could be treated surgically.
Adam, what about the risk of cranial nerve 7 and lower cranial nerve deficit going through that neuromeningeal trunk? It seems that it exactly goes where the blood supply to the lower cranial nerve is.
Yeah, I agree. That's why you want careful, under anesthesia, high magnified microcath views, and you want to have a low threshold for bailing out and saying, all I'm doing is taking a picture.
How do you decide? How do you decide?
Well, you want to see if you can get your microcatheter very distal. I think actually going at that ICA might be interesting, and see if you can get it right into the little nidus. I think there is a nidus there, and block that without refluxing or getting into other branches. But if you don't like what you see, the crew at Miami are very skilled. They can always just get pictures and then turn around and say, look how much better our understanding of the anatomy is here, because we've got pictures of this fistula and we can see the nidus and we can see the vein.
I think, Jacques, you probably took it to surgery, and I think this would be fairly straightforward surgical. You could almost obliterate it in situ. It's like some of those brainstem lesions I showed you. But I would also, bring up radiosurgery. I mean, I think that's another option depending on, what kind of condition this patient's in and how they felt about it. I think that,
Yeah. So just for the sake of time, let Eva to carry on with your presentation.
Yes. Yeah. So we considered all the options that the panel.
Go back, just show the slide for the audience, just to have a quick look at what we summarize, what we talked about. Of course, I discussed it at length with, I can't remember if at the time it was Bobby. I know Bobby got involved later, or Eric. I honestly don't remember. But go ahead, show what we did.
I guess one thing.
Was it you, Bobby, or go ahead?
I was just going to say one thing. I think we may have done microcatheter runs, but I think the one thing to be careful of, because we get these patients transferred regularly from other centers. I don't know if Eva, if you can point out the facial branches off the middle meningeal artery.
Yeah.
So those people embolize those all the time, and the patient is a permanent seventh palsy and often also has a problem swallowing. I think I've seen at least 4 of those. So if you go through those small, the small branches, you're undoubtedly going to give them a facial. Adam's right, though. Sometimes we have gone up the middle meningeal posterior inferior division or the accessory meningeal all the way back around, or even transvenously and embolize these. But usually, we would treat these surgically, or I don't think radiosurgery is unreasonable either. Sorry.
Okay, Eva.
Go ahead, Eva.
So yeah, so we ended up doing a retrosigmoid craniotomy. And so, we hear the lower cranial nerves. We here you see at the 7-8 complex, the fistula component right here. And so I'll just fast forward it just because we're a little short on time. And so here you see we're dissecting, this is the ICA, and there's actually a few branches that the ICA is giving off that then later on goes into the IAC that you can't see in this view right here. And then let me fast forward. So here you can also see that all these, like the fistulous vessels, are actually splitting the 7-8 complex. You see it goes in between here and here. And here, this is like the outflow vein, and then it's draining into the superior petrosal vein, and then later on into the superior petrosal sinus. And that's 7-8 complex. And so we got
like you, Gary, I love the Charbel probe. I'm trying to understand it,
Yeah.
So here, this is something interesting for the audience to see. If you look really carefully, you can actually see the venous and arterial blood mixing right here. It's like pulsating. And so just fast forwarding a little bit more, we dissect the proximal vein and then go around 360, and then we later on put a clip on the proximal vein and then this big vein right here. And so we'll just stop right here and say, after we put on.
Yeah, Eva, yes, stop here. So freeze it. So is it okay to now treat it like a quote unquote simple dural fistula with simple vein ligation, which is what I'm about to do here? Panels, am I doing the wrong move, the right move? What am I doing?
I already said, I think this one hasn't read the textbook, so you might get away with it, but I liked Gary's sort of obliteration in situ idea. This is fine. Maybe you get away with it, but if you can prune some of those branches and bipolar the arterial supply while you're there, I might do that too.
That's what I would do. I'd buzz the AVM, staying away from the 7th and 8th nerves, and then I would clip the vein.
The problem is, Gary, I know we went through the video quickly. I mean, the arterial supply is mixed in with 7 and 8. He has a perfectly normal face, and there is going to be a view in a second. You see the 7 is transparent over one of the veins. I figured I'm going to deafen him and give him a facial if I do what you suggest on the, on the PIA of the brain stem, which I've done too.
And one other thing is that here we didn't clearly see a nidus. We saw lots of feeders, but that nidus type thing that was sort of alluded to on the angel,
correct.
We don't see it here. So I think this is just a very complicated dural PL fistula. It's still a PL. I mean, not a PL really, because by PL I mean PL of the nerve technically, like not the brain stem. But it's still the same strategy, and I would do the same thing of just disconnecting the vein, because going and coagulating the arteries on that artery, on that nerve, would completely make them dysfunctional, at least for a long time.
Eva, play the video and watch what happens.
And so as we put a clip on this vein, you'll see right here, if you look right here, the venous malformation actually starts, this malformation actually starts bulging right here.
So yeah, I said, what the heck? It hasn't read the textbook. It's supposed to die, but obviously I'm not clipping it right off the dura.
So that's very wise. That's a senior move right there, is to not just clip the vein, but watch while you're doing it.
Exactly.
Because you heard Amir, right? That's the real dilemma here. And yes, you should definitely chide this patient for not having studied enough, because this is not following the rules.
So all I could do is kind of partially what you're suggesting. So I clip some ICA branches that I think are not feeding the nerves, and that's it. And I close. Eva, you want to, take us to, I guess there isn't.
Is a small vessel. Why do you clip it as opposed to low cautery coagulation?
I don't know. No specific reason. I could have. Well, I figured because I figured if the monitoring changed, it's not an irreversible move, and I wanted to do ICG, and it was probably a useless clip anyway. Look at the facial nerve. Look how thin it is. You see that?
Yeah.
It's incredible. So I didn't dare get close enough to coagulate on this area. So, and I quit. And Eva, go ahead. To the end. Show the. Yeah.
And so here was just the post-op angio. So, this is the lateral ECA injection again. And then here's just a meningeal MMA selected injection. And then here's the left vert injection again as well.
Not much has really changed. Yeah. And so just to speed up, I did radiosurgery. Yeah. Go ahead with the radiosurgery.
And so we did. Yeah, so we did radiosurgery, and so we actually combined the MRI with an angiogram done on the same day. And so this is the angiogram that was done on the same day. The only thing that was different was that with the left vert injection, now there's no longer bleeders from the ICA.
Interesting. Yeah.
And so.
But that nidus is truly a nidus, actually.
Well, I'll show you what I targeted, and Bobby helped me with performing the very nice angio on the day of the gamma knife, and we teamed up to kind of understand what to shoot at. And essentially, I go to the next one, Eva. Forget the dosage. We did 36 gray. I essentially shot at the suprameatal dura. I mean, where you see what we targeted. And go ahead, Eva. Just again, I'm sorry for the sake of time. And it's gone. It's gone.
What dose? What dose?
36 gray.
Yeah, that's high. Yeah.
Well, 18 is 18 gray to the 50.
Oh, 18 gray to the 90th per.
No. Yeah, well, 36. Well, 36 max, 18 to the.
Yeah, 50. No. 18 is more reasonable because.
Right.
Yeah. 50% isodose. Yeah.
Right.
Yes.
Yeah.
And this is, I think, what, a year, Eva?
It's 3 years after.
This is the final 3 year. Yeah, gone. So, challenging, exact. I still think it's obviously a mixed lesion of some type. Yeah. Okay, Matt, thanks, Eva. Thanks for putting this complex case together. Matthew Sun, let's see the last case of the day.
All right. Last case. So this was a 36-year-old female who initially presented with just headache and blurry vision. CT at the time was negative and she was discharged home. Unfortunately, a month later, she came back with much worsening headache and blurry vision and a new partial left third nerve palsy. Here's the initial CT. And this second CT now shows a area of hyperdensity in the interpeduncular cistern now, which could explain her symptoms. And so we got an MRI. You can see the T2 sequences showing, abnormal vasculature, both in the basilar apex area as well as possibly in the ACOM area. And here's a T1 with contrast. And then we went ahead and performed a CTA. Interestingly, the patient also has a left ICA occlusion on the CTA, but it redemonstrates abnormal vasculature near the basilar apex as well as the ACOM complex. And here is the diagnostic angio, right ICA injection, showing the tangle of vessels near the ACOM complex. And just for the sake of time, I'm going to advance to the vertebral injection.
And maybe, Bobby did this very nice angiogram. Maybe Bobby can also comment on what we're seeing. I mean, without giving kind of the answer, but I guess in the next shots, maybe. the super
Yeah,
selective
I'm going to
shots.
show kind of a 3D reconstruction just so we can see the anatomy a little bit better.
But it's
Um,
important to note, I don't think it's shunting.
Yeah, exactly. Where is the venous drainage? We don't see. It almost look like that there is only arterial malformation without.
You're too sharp, Adam. I mean, this is why.
Exactly.
That's 100%
Exactly.
as well. So carotid, you actually see near occlusion of the carotid with the string sign. And here is the 3D reconstruction. I'm just going to fast forward to show you when we can manipulate this area here, you can see a flow-related aneurysm better. And obviously these vessels are coming off of the left P1 near the basilar apex.
And she actually had a complete third, like her eye, when she came back, we were never consulted the first time, and when she came back, her eye was completely shut. And you're right, if you spin this in all directions, there's no early venous drainage of this.
So I guess the question for our speakers, how would you classify these lesions?
Arterial malformation.
Yeah, we all agree that this is the so-called pure arterial malformations, PAM. Giuseppe Lenzino has a nice paper of 12 of those that he's seen.
Yeah, I reviewed this recently because we had a case that we thought was an AVM, and I resected, and it turned out, looking back, it was a pure arterial malformation. We don't know what the natural history of these is, but it seems to be pretty benign, that there's some developmental anomaly.
Yeah, it's interesting that she showed up with a third nerve, though, Gary, don't you think?
I do think it is, but
yeah, no, this is unusual.
this is very unusual. And is the aneurysm, where's the aneurysm exactly? Is it near the third nerve?
Yes, and it is near the third nerve in the intercrural cistern.
Yeah, I'm just wondering if the aneurysm is causing the, development of the aneurysm is the problem.
Oh yeah, no question. There's no question about that.
But I don't think that these bleed if they're pure arterial malformations. So I would probably direct treatment towards the aneurysm in this case.
So we thought we agreed with you guys. We thought let Bobby have a first go at it endovascularly. And I don't know, Bobby, if you want to kind of the meticulous thing we tried.
We won't be able to summarize it now, but we did probably 10 micro catheterizations and runs and actually mapped out each of those vessels. There was no way to embolize this without getting embolic material into a number of other vessels. I think provocative testing, you can also consider doing that. And I can't remember if we did a lidocaine and Brevitol and micro injections here. I don't think we did.
No, I remember you telling me you were one bifurcation away from getting to it. And and when you injected it, I think you used, I don't remember what you used, but you were having, it was, you couldn't take it prior to that bifurcation point.
Yeah.
Because by that, it was so tortuous by then.
Yeah, and so that's exactly what we did, though. I mean, she has an ACOM pure arterial malformation that we left alone. She has this basilar pure arterial malformation that we really left alone, and we just went in and put a clip on the proximal feeding vessel just before the aneurysm.
So go ahead, Matt, with the.
Yeah, so just going to show a quick video of what we did in surgery, just to refresh everyone's memory. That's kind of the proposed vessel. And we did a left cranial orbital approach. Here's the overview here. Here's just kind of for our general audience, the advantage of doing a cranial orbital approach where you can look more superiorly if you remove the orbital rim. Again, you can have a more direct view of the lesion if you remove the orbital rim in this case. You can see a hypoplastic supraclinoid carotid consistent with the near occlusion. We performed a complete transsylvian dissection and a partial guncal resection. And then after we place the retractors, you can see beyond the carotid circulation, you can see the third nerve in the distance and the posterior communicating artery just on top of it. So the first thing that we did was to dissect the posterior communicating artery from the third nerve.
Kind of nice that the carotid's so hypoplastic.
Isn't it interesting? And I think this carotid occlusion has something to do with the PAM formation.
Mhm.
As long as you don't get her blood pressure too low at surgery, it's nice.
Right. And so here, just go ahead.
No, I was just going to say, presumably that's happened over a long period of time and she's not particularly vulnerable, but I don't know.
So now, of course, it was here working like through spaghettis, figuring out which spaghetti to clip. And obviously, Bobby's very lovely angiogram, you know, you had to go back, look at the angio, look at the surgery, try to figure out which vessel is which. We knew which one we needed to put a clip on. Because we never saw the aneurysm, but we just grabbed the proximal vessel to it and just put a clip on it.
Jack and Bobby, this is where an augmented reality would be also very helpful.
Yes, you're right.
Show you the distal aneurysm and you can just track the vessel. That would be really good. A accurate augmented reality would be very helpful here.
Yeah, I think the hard part of this case is you have to have a crystal clear reflection of the angiogram here because it just looks like a bag of spaghetti. So obviously we had neural monitoring so that when we could put a clip on it, we knew, there was no changes. And I think we did an intraop angiogram as well to show that we occluded the aneurysm. And I think this was in 2017 or so. I think I followed this lady for 4 or 5 years. Her third nerve completely resolved. And then
fairly quickly, I remember too, Bobby.
Yeah, and then I followed her, I continued to follow her. She still has the pure arterial malformations, which has been changed, no new aneurysms, no new clinical problems. And I think she's got at least 4 years of follow-up now, but her eye was completely closed and out and it went completely back to normal.
Interesting pathology, isn't it? So we thought
That's fascinating. Great result.
Great case.
Yeah. Okay. Well, we've kept you. It's almost 7 p.m. Eastern time. I cannot tell you how much I enjoy being with colleagues, particularly smart colleagues and accomplished colleagues like you. Any last minute questions, comments to each other? Otherwise, I will let us all go to our evening.
Jacques, thank you very much. Thank you. These forums are fantastic. I'm honored to be invited and I hope to be invited again. And
I'll just reiterate what I started out saying, and Charlie Drake told me back in the 1980s, AVMs are the toughest lesions to treat.
Yeah.
And they still remain that.
No two are alike, indeed. Thank you for the audience for sticking with us. We went well over 110 at one point, and good night, everybody. Bye.
Thanks a lot.
Take care, guys.
Bye-bye. Thank you.